is Rory speaking with Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It's October 2023, and we're back again. Ryan, how you doing?
Doing great. How are you?
I'm here. It's October. It's fall. Things are great.
You keep on saying this fall. I don't know what this is all about. Mid-spring, gorgeous days.
Yeah, I think fall and spring are both the best times of the year overall. So it's when you get to summer and winter that we're in dichotomous outcomes.
Climate change.
All right. On that note, let's jump into the articles before you start rattling on about the weather. Our first article is sedative dose for rapid sequence intubation and post-intubation hypotension. Is there an association? And this is lead author here is Brian Driver. And so the idea here is that in sick patients undergoing RSI, they have a tendency to try to drop their blood pressure and at times have a cardiac arrest during the peri-intubation period. And the thought is, whatever illness is causing you to intubate them gets worse when you add positive pressure ventilation and a sedative, which takes away some of the patient's sympathetic surge, losing some of their venous tone and arterial tone, causing hypotension. And if that hypotension is bad enough, leading to cardiac arrest. And so the thought is that you can adjust your sedative medications, meaning lower your sedative medications in these sick patients to try to alleviate some of the hypotension we see in this cohort. As this author group points out, there's no real evidence suggesting this. There's a lot of expert recommendations to do this, but the evidence supporting this is fairly limited. These authors looked at the NEAR database and they examined from January 2016 to December 2018, looking at patients 14 or older who were undergoing intubation with either etomidate or ketamine. And they looked at the drug doses in milligrams per kilogram based on the patient's weight. And they wanted to see if there was an independent association with post-intubation hypotension, which they just defined as a systolic blood pressure less than 100 within an hour of the intubation. They looked at a lot of intubations. So over 12,000 intubations with etomidate, over 1,800 intubations with ketamine. The median drug dose for etomidate was 0.28 milligrams per kilogram. And the median dose for ketamine was 1.33 milligrams per ketamine. And the median dose for ketamine was 1.3 milligrams per kilogram. Post-intubation hypotension occurred in 16.2% of the patients who received etomidate and 29% of the patients who received ketamine. And so this is pretty consistent with other data sets that have looked at post-intubation hypotension in ED patients undergoing RSI, somewhere between 20 and 30%. So this is fairly in line with this. When they conducted a multivariable regression, looking at the other variables that may or may not cause hypotension, they found that there was no relationship with the dose of the medication they got and the rates of hypotension peri-intubation. They looked at a number of sensitivity analysis. Most important here, the big limitation is essentially this wasn't a prospective study. Patients were randomized to get a weight-based dose, to get a lower dose if they were in shock or not. And so it's hard to say whether the dose they got was based on how sick they were. So for example, if you're intubating a super sick patient who already is hypotensive and you have fear that they're going to arrest during the intubation process, you might lower your dose. And so you might prevent some hypotension, but because you're now selecting for a sicker population, we might not be able to actually see a difference in the outcomes of this study. They looked at this a couple of ways. They obviously controlled for patients who were super sick with hypotension prior. They did a sensitivity analysis looking at these patients. They also looked at the sites that used just basically the same dose for everybody. So everyone got 20 milligrams of etomidate, no matter what their weight dose is, no matter what their illness was beforehand. It was really just almost an automatic dosing. And again, even in that cohort, you weren't able to see a real difference in the weight-based dosing and an association with hypotension. So I think it's interesting. Again, I think because the limitations of how this study was done, we can't say for sure there's no weight-based dosing effect or there's no dosing effect on hypotension in these patients. But I certainly think there's a lot of other factors in play here that leads to these patients becoming hypotensive. And the dose itself, you may or may not be able to have too much effect with the outcome.
Yeah, I mean, I think that's just it's fairly muddy data, and there's probably a lot of unmeasured confounders, and it's a prospective registry, but that still depends a little bit on a little bit of recall within the setting. It's not automated data capture with that's sort of relatively bulletproof as far as detecting every sort of adverse event associated with the peri-intubation period. And then, of course, I don't really necessarily think of etomidate and ketamine as our biggest culprits as far as inducing hypotension, like adverse effects in the peri-intubation period as well. So I'm not really surprised to say that, yes, there's probably not a difference as far as weight-based dosing goes for these agents. But then again, these data only have as much quality as they have.
Yeah, I mean, I think the one thing we know for sure is like these agents aren't protective, right? As you can see in this cohort, 16 and 29% respectively of those who got etomidate and ketamine still dropped their blood pressure, right? And so most of this is dependent on the physiology that you're seeing in front of you and how sick the patient is. Patients who are in shock prior to intubation most likely are going to worsen their shock during the peri-intubation period. I don't think we can say that weight-based dosing is protective in any way, but what we sure can say is you should still be ready for them to drop their blood pressure, whether you're using ketamine or etomidate or not, right? Because it's going to happen in a good proportion of these patients.
Yeah, I mean, this is just increasing intrathoracic pressure and all the other changes, is transferring somebody from spontaneous ventilation to a mechanical ventilation, and no protective effect that's obvious here. But again, there's only so much you can rely upon these data, anyways.
Do what you're going to do, but just be ready for them to be hypotensive and have your tools there to be prepared for it.
Well, let's move on to our next little critical care type sort of article in this journal. This one is called A Temperature and Age Adjusted Shock Index for Emergency Department Identification of Pediatric Sepsis. Our lead author here is Nathan Georgette, and they are at Boston Children's Hospital. And so finding sepsis in children is both easy and hard. On one hand, it's easy. Our pediatric advanced life support cutoffs trigger us to evaluate for sepsis with nearly 100% sensitivity. But as we've discussed previously and ad nauseum on many a podcast, 100% sensitivity frequently means very poor specificity. The PALS cutoffs are going to give us a range of specificity around 16%. So very sensitive, not specific, but we catch all the cases of sepsis. Highly specific tools, like the International Sepsis Consensus Conference criteria, get us to 75% specificity for the picking up pediatric sepsis, but only 50% sensitivity. So these authors tried to do better. In this instance, by incorporating temperature, like febrile temperature, and age adjusted shock index into their own novel tool. They used their institution's data warehouse to validate and to test their model and compared it to heart rate or blood pressure cutoffs within PALS. Using over 140,000 patient visits, 4,700 of which met their retrospective definition of sepsis, which was antibiotics and resuscitation, or an ED diagnosis related to sepsis. Septic shock was defined as sepsis with administration of vasoactive agents, and there were 500 of these. They calculated and calibrated their shock index model in two ways. First, to maximize sensitivity, and then a Youden indexed cutoff, which strives for the best balance between sensitivity and specificity, while still costing false negatives, the ones you don't want to miss, greater than false positives. Without belaboring this further, however, we'll jump right to the end and say it didn't really work. From a clinical standpoint, their predictive skill was grossly no better than just using PALS. So, excellent work for the effort to pull all this together and explore this line of prediction. Regrets that we'll ultimately need to innovate a different strategy. And then, of course, compare it both with PALS, but also unstructured clinical judgment, if that even exists anymore in this modern world of ubiquitous systems.
I think that last line's perfect. I think all these endeavors, when you're trying to like identify sepsis, especially when we're using these like big data sets with like a retrospectively defined sepsis as antibiotics and some form of resuscitation, is limited, right? Like you're basically what you're trying to do is try to find a set of variables that is going to identify the risk of someone developing sepsis at some point during their hospital stay, and you're never going to get a low enough sensitivity to actually be beneficial because sepsis is a complicated disease that is sometimes hard to diagnose in a single moment, right? And that's why time is your best diagnostic factor. Giving yourself time to observe people and see how they progress, usually sepsis becomes fairly obvious at some point, and as long as you're paying attention to the patient, you can see them. I think the better way to look at this is put people in like risk bundles, right? What was the overall risk of decompensation over a certain period of time? And when you do it like that, you kind of have a better picture of what kind of patients you're going to put in each bundle. And you can find a low risk population where, if they don't have certain factors, the risk of them going on to develop sepsis or need a resuscitation and so forth becomes incredibly low. And I think that's probably a better model of looking at this than what we're doing here, which is like trying to find a test that has both sensitivity and specificity at a single time point with a disease that is very variable and looks very different in multiple people and multiple ages, multiple pathogens, so on and so forth.
I also think the best perspective to look at it is from the shoes of an administrator and the hospital value based payment system in which they're going to incorporate SEP 1. And so you need to be 100% sensitive so that you can initiate all the treatments required for the protocols up front so that there are no fallouts, so that your hospital gets all this money. That's really what we're worried about here.
Right. I mean, so I think that's the that's the other problem, right? When we look at things from having a goal that may or may not be appropriate for the patient, it's going to be really hard to have outcomes that are beneficial to patients, right? But if we want to look at the financial benefits to the hospitals, then we can usually do, which is we cheat the numbers, make it look like it's not sepsis, and so on and so forth.
Which I'm not saying these authors are interested in. I think these
No,
authors are actually interested in doing the right thing for these patients.
course.
But yes, no. Moving
All
on.
right. Moving on. Our next article, temporal trends in the incidence and survival from sudden cardiac arrest manifesting with shockable and non-shockable rhythms, a 16-year prospective study in a large U.S. community. And the lead author is Laura Holmstrom. These authors wanted to look at what was going on with out-of-hospital cardiac arrest, meaning how many patients are we seeing with VFib, the most favorable initial rhythm, versus PEA versus asystole, and what was the survival trends for each of these respective rhythms. Using the Oregon Sudden Unexpected Death Study, the authors prospectively evaluated the incidence of each presenting sudden cardiac arrest rhythm and the survival outcomes. The Oregon Sudden Unexpected Death Study is essentially a prospective, ongoing, community-based study where they record the rhythms of cardiac arrest and the outcomes of these patients throughout the state. The authors looked at overall of 3,723 cardiac arrest cases, 24% presented in PEA, 41% in VF, and 35% in asystole. The incidence of PEA and asystole remained fairly stable over this 4-year period, whereas the incidence of VF decreased over this same time period. On the other hand, survival increased for PEA over this time at 5.7 in 2002, all the way up to 13.6 in 2017. This trend was also seen in VF arrest, 27.5% in 2002, all the way up to 36.6% in 2017. Unfortunately for asystole, there was really no increase in survival, and it remained fairly consistent throughout this period. The authors kind of proposed some reasons why we might have seen this increase in survival over this time period, and they suggest that over this period, the EMS systems in Oregon introduced a number of treatments that may have improved survival, both for PEA and asystole, using IOs in 2007, hands-only bystander CPR in 2008, supraglottic airways in 2009, therapeutic hypothermia with cold saline in the field in 2013, and then mechanical CPR in 2015. The thought here is by introducing all these factors, you might have improved survival mainly for that reason. Now, I think I'm a little more skeptical because we have multiple RCTs looking at almost every one of these, and none of them have actually found a survival outcome in patients. And so it's hard to imagine doing these things actually was the reason for improved survival. It may have just been that we're paying more attention to patients in cardiac arrest, so they're getting better overall care. We see that all the time. But these actual introduction of these therapies, I'm sure it's probably not the exact reason why we're seeing the survival benefit.
I mean, I think that they've really left off a lot of the things that are actually probably important from this list. Things like AEDs out in the community, the sort of increased sort of awareness that bystander CPR is really important and that you can actually save lives by just getting down there and doing chest compressions. I feel like those things have culturally become more prominent than they were, back in 2002 or whenever this study started. I think those are the sorts of things that are going to have more impact on survival from out of hospital cardiac arrest actual interventions that they've all described, which all of them in isolation, yeah, they've been tested and they don't really seem to show a huge, profound difference in survival. But they are part of also this idea that we're going to try a lot harder in these patients and we're going to put them in the unit and we're going to actually not just declare them brain dead within the first 48 hours. We're going to actually cool them and work on them and normalize their physiology and then try and wake them up and warm them up and see what happens. And so I think there's a lot more invested in patients who have arrived at the hospital from an out of hospital cardiac arrest over the past couple decades than there was perhaps back in the very beginning.
Yeah, I think that's probably fair. I think we've seen whether you cool them or not, just the effect of cooling them kind of gets rid of the nihilism that you have for managing these patients, which tends to improve survival overall.
All right, we shall move on to the next article from this month's journal, and it's entitled Heart Score Recalibration Using Higher Sensitivity Troponin T. Our lead author is Aleem Khan, and they're at the Liverpool University Hospital. So, the heart score has been, still is cool, I guess. It's certainly been incorporated into a lot of clinical pathways across the world. The good news, despite being effectively dreamed up over drinks in a pub, it works. It does a pretty good job of appropriately weighting the sorts of things we consider clinically sensible into an objective measure of 30-day risk for major adverse cardiovascular outcomes. The bad news is the heart score is old. The T element has become a bit outdated, considering conventional troponins have been entirely replaced for the most part with high sensitivity troponins in many settings. Now, in this trial, the experiment is whether the old T score, which used like a normal limit and 1 to 3 times the normal limit and 3 times the normal limit for scoring, can be replaced with scores calibrated to the limit of detection and the 99th percentile for high sensitivity assays. To validate this, these authors conducted prospective cohort studies enrolling patients in both the UK and the USA, using new troponins to compare the new heart calibration with the old, as well as, just for old time's sake, a recalibration of the TIMI score. And then, just to muddy things further, they also compare heart against simply a negative troponin result in a non ischemic ECG. Without getting into the weeds of the technical details and the adjudication, the basic gist boils down to higher sensitivity is, well, higher sensitivity. And as we discussed already on this podcast, the other side of sensitivity is specificity, which naturally suffered, which in the end makes this a bit of an odd report. Because on one hand, it clearly shows the heart score with high sensitivity troponins is simply just turning the dial a bit on the old heart. And actually puts more patients in this gray zone requiring further evaluation, with the small advantage of catching a few additional cases to tick up sensitivity. So it either does worse or better, depending on your view, leaving us then with the takeaway the authors present, which is that incorporating recalibration is at least better than not using any clinical judgment at all. That is to say, it's better than just having a non-ischemic ECG and a troponin below the limit of detection, but it's just basically the same or worse or better than the previous heart. And that's a reasonable look at these data. What validity heart had, a contentious point, is not made obsolete, and its incorporation of risk factors and other clinical criteria adds something to its predictive ability to expand the low risk cohort. Now, the authors keep framing these data in the context of percent potential discharge, which commingles a predictive model with prescriptive instructions without introducing evidence a particular non discharge strategy goes on to improve 30-day major adverse cardiac events, and describing reliance on a predictive model to support a clinical pathway that also ought to be compared with routine clinical judgment. But I digress. This is a rant beyond the scope of the paper. If you use heart, this is a reasonable approach, in principle, to incorporating high sensitivity troponin into the algorithm.
I mean, I think the big thing is most of the time you don't have a choice, right? It's not like you can choose between the fourth generation troponins and the high sensitivity. You have what you have at your hospital, and you kind of have to incorporate it as it is. I do think this kind of misses the problem with heart. The problem with heart wasn't that it wasn't sensitive enough. The problem was you had a whole bunch of people that were heart score 4, 5, and 6 that were admitted to the hospital, and most of them did fine. And you needed
Still
a
are.
way, right? Right.
You talk about did.
Yeah.
They still do that.
Right. And
They're not
so,
having acute coronary syndrome, but their heart scores are high because they walk around to the grocery store
right.
with their heart scores of 4, 5, and 6.
Right. They walk around with a heart score of 6 at all times, and they just show up in the emergency department. They're going to get admitted to the hospital. And so the problem was trying to add some increased specificity to the score. Now, adding a more high sensitivity troponin, as you said, just kind of shifts your place on the ROC curve in the wrong direction, unfortunately. And so while you do gain a few extra cases you would have otherwise missed, you also just drop your specificity. I also think it just looks at the wrong outcome. Can we stop looking at MACE? It's for the most part an unimportant clinical outcome. There's stuff in there that is important, death and STEMI. But the rest of the stuff, I'm not sure it matters. It doesn't matter if you get a revascularization. One could argue getting admitted to the hospital encourages that revascularization rather than it, or is the cause of it. And then, if you come back a few days later and your troponins elevated, that's not really a bad outcome. That's just good follow-up instructions. The stuff we're concerned about missing is massive STEMIs and death, or unstable rhythms, right? These are the things that we should be tracking to see what our real miss rate is of stuff that's really bad that happens. There are papers at this. It looks at that, like intermittent heart score patients are 4, 5, and 6 who were admitted to the hospital and what happened to them during their stay. And surprise, surprise, most of them do completely fine. Nothing happens to them. They don't have any, they have some troponin leaks and some type 2 MIs, but they don't have any STEMIs. They don't have any VFib arrests. They don't have any massive heart attacks that cause death. And so I think we have to change what we're looking at, and we have to stop trying to identify every tiny little outcome that may or may not happen and rather look at the clinical meaningful ones.
Yeah, I mean, I feel like MACE basically came out of a bunch of pharmaceutical design trials who wanted to increase the ability to detect a difference between two sort of like, antiplatelets or, anticoagulants or whatever as going to be some sort of treatment to enhance their ability to diverge the two groups without actually making a clinically important difference in patients' lives. So we should probably not inherit that perspective as well. We want to make sure that people don't drop dead within 48 hours from some big thing we've missed. And then everything else that happens after that time frame is pre-existing physiology that we couldn't modify whether they were put in the ER in the hospital. So
yeah, and maybe it could be longer than that, right? Like maybe the ED stay does have effects, up to a month, 30 days, but we should be looking at the outcomes that matter in 30 days, right? Like again, like if a score fails to identify someone who's going to have a massive heart attack 15 days after they present to the ED, maybe that's something we'd like to know. But I'm not sure I care that the score predicts whether they're going to get a stent placed in 13 days.
Yeah. And then the idea that heart, by predicting these outcomes, also tells you what you should be doing with these patients is the problem as well. That it doesn't tell you what to do and it doesn't tell you how to prevent those bad outcomes. People have just decided that since they're not low risk, they potentially should be admitted to the hospital. Not every hospital system does that, but I think it's worth thinking about when you have heart 4, 5, and 6 patients, whether you've done what you need to as far as modifiable risk factors for an adverse coronary outcome. But that doesn't mandate admission to the hospital.
Yeah.
It mandates thinking.
But for the record, once again, we've looked at a study of high sensitivity troponin that hasn't really improved any outcome.
Well then, let's look at something that does. Come on, let's look at a good trial. Maybe is our next one good?
This is a good trial, an interesting trial. I like the thought here. Diagnostic accuracy of clinical pathways for suspected acute myocardial infarction in the pre-hospital environment. And the lead author is Richard Bodie. So this is interesting, right? This is the idea that we transfer a ton of patients with chest pain to the emergency department to rule out MI, and looking at maybe there's a way that the paramedics pre-hospital can be like, you know what, you're probably not having a heart attack. You probably don't have to waste the time and the resources involved in going to the emergency department to have a full. And so what they looked at was a number of scores, seeing if these could help. Now, a couple of these scores required troponin, heart score that we just talked about, and the Tmax score. And so they looked at those scores using a point of care troponin, and then they looked at a couple of just clinical variable only scores, the HEMAX score, which is a great name, and the HERE score, which is essentially the heart score without the T. And they conducted a prospective diagnostic accuracy study. It was 4 ambulance services and 12 emergency departments between 2019 to 2020. And they included patients who received an emergency ambulance response and whom the paramedics suspected an MI. Overall, there was 817 patients, out of which 12.8%, so a reasonably good number, had an acute myocardial infarction. A further 16 patients, or 2%, were diagnosed with a type 2 MI within the first 30 days, all of which except one happened on the index of admission, so when they were brought to the hospital. So if you look at the two clinical variable only scores, so the ones that you don't need a troponin for, this was the HEMAX score and the HERE score. If you look at the HEMAX score, it performed incredibly well from a sensitivity standpoint. Zero missed MIs in that group. The HERE score performed slightly less optimal from a sensitivity standpoint, with 5.6% of the population in the low risk group having an acute MI. Unfortunately for the HEMAX score, it was essentially clinically useless, again, from a specificity level, because only 2.6% of the population were who are actually in this low risk group who would require not having to be transported to the hospital. Now, if you look at the scores with the troponin, the Tmax score performed fairly well, again, with only 0.9% or one patient having an acute MI when they were in the low risk group, compared to the heart score, which had 4.1% or 8 patients having a type 1 MI when they were considered low risk. So, an interesting concept. I think there's a couple issues here. One, the troponin was drawn in the ambulance, but then brought to the hospital to be analyzed within 4 hours. So, it's not really a real life situation where they're running a troponin in the back of the ambulance. So, you'd like to see an actual real life situation where the troponin is being run in the ambulance to see if it's actually a viable option for these patients. I think there is a concept that maybe we could decrease some of these patients being transported to the hospital. Unfortunately, I think this has shown you don't really get much bang for your buck. As soon as you start to develop a score that is sensitive enough not to send people to the hospital, the actual rule out rate is just way too small to be clinically useful.
Yeah, I think I have no problem with taking a patient who has just a potential diagnosis of acute coronary syndrome, and you're worried about acute MI, and running a troponin either in a in whatever pre-hospital setting, whether it's the back of an ambulance or a rural clinic or a whatever it is, office setting, urgent care, anything like that, any non-acute care setting, effectively. It's the same assay as we run in the hospital, basically. We run a point of care of troponin in the hospital, in our emergency department. It's literally the same assay that they run in the back of the ambulance. Same results, same information. They can get an ECG. We can get an ECG. We're working with the same information. In principle, no big deal. The thing is, like, if you look at supplementary table 3, they rule out acute MI, but there's also there are alternative diagnoses that may or may not require evaluation in the hospital. So there is some extra thought process and some potential extra evaluation that needs to go into thinking about pulmonary embolism or pneumonias or aortic aneurysms or biliary disease and those sorts of things. So not every patient's going to be eligible for this either. I think some of it's there's some idea maybe that people are being triaged or transported to coronary centers, and this might help potentially take people who don't necessarily need urgent revascularization and PCI to a less specialized hospital where they can run, like do basic labs.
Couldn't you do that
But
with an EKG?
in theory, maybe. But in principle, I like the idea that they're looking at least introducing the idea of you don't have to run troponins and exclude people from acute coronary syndrome in a hospital. You can do it other places, even and obviously this information, these clinical ideas, there was never any I don't think there was any validity to considering them as useful, because we've known for a long time that clinical judgment does not exclude acute coronary syndrome. These heart scoring systems, the HERE without the T and the HEMAX, there was never any face validity that those would be adequate for ruling out an acute coronary syndrome in the pre-hospital setting anyways. The
Right.
troponin is useful.
Yeah, I mean, like we said, you just kind of walk up and down your ROC curve. You're going to have a fixed curve essentially with a clinical diagnostic score. As you said, you can only get so good, and so you're basically walking up and down a curve, and you're limited by the curve, and that's why you see when you're shifting it over to get really sensitive enough to rule out MI, you end up being so non-specific it's unusable.
I mean, I like this. I think we're doing a similar trial here in the South Island, New Zealand, because we have so many far flung, low resource environments that we almost have to do this to prevent people from having these massive transport times to an acute care setting, and trying to do as much sort of virtual care in the remote rural settings, so supported by point of care troponins and ECGs, to see if we can safely treat and triage patients, to less acute settings for evaluation of their chest pain. So, it's totally valid. Good work. All right. On an entirely different topic, our last article that we're going to focus on from this issue is the acceptability of long versus short firearm safety education videos in the emergency department, a pilot randomized controlled trial. Our lead author here is Maya Haas, and this is at the Children's Hospital of Colorado. This is an interesting little trial looking at firearm education in the emergency department. The basic premise that there is prior work demonstrating video based educational offerings provided to patients during their acute stay are useful and acceptable. So, how about a firearm safety video in the emergency department? Taking place in Aurora, Colorado, these authors randomized patients to a firearm safety video or a firearm safety video. The difference, one was 30 seconds long and the other was 3 minutes long. The primary outcome was quote unquote acceptability, ranked on a 5-point Likert scale, and an acceptable video was defined a priori as an acceptability rating of 75% agree or strongly agree. And so the answer was yes. 87% of the 250 enrolled thought that the videos were quote unquote acceptable. And then the complexities and limitations set in. As you can see, it's only sort of a randomized controlled trial, since their primary outcome is really just a prospective cohort study that whether a video is acceptable, and they're all getting a video. But then they do have the sort of randomized exposures for their secondary outcomes. And the gist of the which video is better is that the longer 3-minute video was thought to be better, and the 30-second video was just thought to be effectively too short. Out of the 250, however, only 81 individuals had guns in the home, 8 of whom reported storing the guns unlocked. And in theory, a sort of patient oriented outcome would be whether the storage of those guns changed after watching one of these educational videos. A few owners watching the longer video expressed interest in doing so. However, in their 3-month follow up, that wasn't asked. Rather, they asked about content recall from the video. Recall was at least slightly higher from the 3-minute video, along with fewer false recall events as well. And then Colorado, particularly suburban Denver, is certainly its own unique location in the United States as far as acceptability might be concerned. So it's challenging to take away much from this other than it can be done. Is it useful? Is it truly acceptable as a generalizable fashion? Not really any data here. However, if you're looking at this as a pilot, and the future intention is to measure some sort of objective downstream effects, then it is reasonable to suggest that your starting point ought to probably be the longer video if you're going to be interested in demonstrating positive results from some sort of interventional trial.
Yeah, I guess you could almost look at this like a dose range finding study. Where it's like,
how much firearm safety can you safely handle?
Right, and like you said, it's probably
What's the
way
toxic dose of firearm safety videos.
Well, I bet you it's far lower in Texas than it is in Colorado, right? And so there is obviously, depending on where you are, an external validity here. But yeah, I think like you said, it's just there's not enough real outcomes here to know what's good. I mean, just like 30 seconds just seems too short. It doesn't seem like you can really accomplish much, but
it's like a TikTok,
right? I mean, yeah, which some would argue is plenty of time to get your message across.
Too much Gen Z time,
right?
30 seconds is an eternity.
Yeah, and even then, we can't even say what if it is right or wrong, because maybe 30 seconds is plenty of time to get the one point across, which is store your weapons safely, because they didn't really look at that as far as an outcome. But I think it's a nice model to do further research and kind of actually start moving towards some real patient appropriate outcomes. And unfortunately, because we're in America, lots of people have guns at home, and there was a decent amount who were not stored safely.
Yeah, and then you worry about the reporting on some of these things because people aren't necessarily going to be truthfully reporting whether they store their guns at home. And then when you call them 3 months later and say, "Hey, you watched an educational video in the emergency department about storing your guns safely. Are you storing them safely now?" Well, you have some reporting issues there potentially.
Sure.
Yeah, tough topic to study, but here we go. 33 minutes is probably where they should be going with. At least, I mean, who knows if it's better than 10 minutes though? I mean, we only have these 2 data points.
You have to start somewhere. There's unfortunately not enough research going into this area. And so at least now we are starting to get research in the area of firearm safety.
True.
All right. I think that wraps us up for another month. Until next month, any questions, comments, or concerns, we can be reached at annalsaudio@acep.org. Otherwise, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.